Good evening, ladies and gentlemen. I'm Faisal Nabi. Today is Thursday, March the 5th, and welcome. We would like to welcome you to a newly launched monthly webcast from DeBakey Cardiovascular Live, Multi-Modality Cardiovascular Imaging. We'll come to you live every Thursday, first Thursday of each month at around 5 p.m. Central Standard Time, to discuss topics that are related to multimodality cardiovascular imaging. This is an interactive format. Please feel free to send us any questions you have. You can text us at DeBakey at 37607 to join the conversation. We'll answer all your questions live on air. Well, it's a real pleasure to introduce my guest today, Dr. Su Min Chang. Su Min is my colleague here at Houston Methodist. We started together our journey here at Houston Methodist several years ago, and is a true expert in cardiac CT. Su Min did his medical school in Argentina, and then proceeded to complete both his internal medicine and cardiology at Baylor College of Medicine. He's been at the faculty here at HMH for the last at least 10 plus years, and is a true expert in cardiac CT. Today we'll be discussing advances in cardiac CT. So Su Min, if you don't mind, let's get started.
Absolutely, thank you, Faisal.
So Su Min, you know, here at Methodist now, whether it's in the emergency room or patients with chronic stable CAD, more and more I'm seeing our physicians using cardiac CT as an imaging modality to image for coronary artery disease. And I know there's been a lot of recent excitement in this field. In fact, a lot of guidelines are now supporting its use. And I just wanted for you to give us an idea of why has this technique become so popular?
Indeed, you're correct. I think we started doing CT here at Methodist Hospital about 15 years ago. And not until 5 years ago, we were doing about 1,000 cases a year, and now we're almost doing 4,000 cases a year. And there's multiple reasons why the coronary CTA has become so popular, as you mentioned. Basically, it's related to a couple reasons. Number one, the scanner technology has become so sophisticated. It's so easy to generate very spectacular and accurate images of coronary anatomy. Number two, unlike anything we've seen before with a non-invasive cardiovascular imaging technique, coronary CTA community has amassed a tremendous amount of data within the last 10 years in terms of diagnostic accuracy and prognostic information, and demonstrated benefit in managing patients with suspected coronary disease compared to what we do traditionally. As you know, not until CTA come along for the last 20 years since our training, the way we manage a patient who show up either in the ED or office for chest pain, and we think this could be related to coronary artery disease, we haven't done too many changes. And the fact is, there's a big study published in New England Journal of Medicine showing that in over 60% of the patients who go to the cath lab after being evaluated for chest pain, and many of them have gone through stress tests, over 60% has no significant coronary disease. So you can imagine the waste, the resources, and I think coronary CTA could change that and make a difference in how we manage patients more efficiently.
That's very true. So if I had a choice as a clinician, and I have a patient who presents, let's say, to my clinic who's having chest pain, when it comes to choosing one of our traditional tests, whether it's a stress echo or a nuclear-based study, why should I go for the CT? How, you know, what are some features? How can I trust what I'm getting is accurate? What is some of the data behind its
You know,
benefits?
Our traditional approach, as you mentioned, patients come to our clinic, we have chest pain, we usually evaluate their risk and we decide if it's low to intermediate risk, we proceed with a stress test. And the stress test has worked very well, very well. We've done a lot of research in this respect. It's very accurate, has excellent prognostic value. But the Achilles tendon is the following. When you have a stress test which is normal, you still don't know if the patient have underlying coronary artery disease.
That's right.
Okay? All we can say is patient does not have significant, severe, hemodynamically significant coronary disease or stenosis. We usually have stenosis from 50 to 70%. And by then, I think, if you have 50, 70%, the coronary disease is quite advanced already. And coronary CTA offered the opportunity for you to not only assess the coronary stenosis, but also to see if the patient has underlying non-obstructive coronary disease. And that, I think, one of the main reasons why coronary CTA is so appealing, because since we have a lot of pharmacological and behavioral means to reduce the risk of future cardiovascular event, knowing the patient have or not coronary atherosclerosis is essential. And also to convince the patient they need to make changes to avoid having a heart attack or stroke in the future.
I see. So if we see atherosclerosis, and even if it's not stenotic, we know that this patient is higher risk than another patient who may, let's say, have completely normal coronary arteries.
Correct. As you know, we together we published this paper, this almost 5-7 years ago, in almost 1,000 patients. They all have stress tests, and most of them are normal. And we see some patients who had completely normal stress tests, after 3 or 5 years, they're starting having heart attack or die from heart attack. And there's some group of patients who are doing well, and you cannot tell them apart from the beginning. And we look back, and they all have some type of CT done in their heart. And those who have event after 3 to 5 years, starting with a normal stress test, are those who have underlying coronary atherosclerosis. And those who have a normal stress test and no atherosclerosis on CT, we follow them up to 10 years, and almost nobody died from heart attack, and very few of them end up having myocardial infarction. And the study recently, the published study, Promise, you're aware of, and Scott Hart, which they compared tens of thousands of patients with a CTA first strategy, meaning the patient come to the clinic with suspected chest pain, coronary disease, likely. They first get a CTA, or they get what we call standard care, which most of them are stress tests. So CTA showed that the strategy of doing CTA is at least as safe as what we do traditionally. And if you lump 3 of the largest studies together, there appears to be a signal, some people think statistically significant, to 25 to 30% reduction of myocardial infarction if you do coronary CTA first. And when they go back and when they went back and look at who actually the one benefit from doing the test, are those people who have less than 50% stenosis but have coronary atherosclerosis. And then by the end of the study, they were taking more cholesterol-lowering therapy, aspirin, blood pressure medication. And we believe, obviously, this is association. We cannot prove this is a causal, but I believe that's a very important aspect why potentially using coronary CTA first could maybe improve patients' outcome, because patients know they have disease, they have incentive to be compliant, and physicians are more likely to prescribe medication that we know could prevent heart attack and stroke.
Okay. So it's the fact that you can see the plaque and then act on it, as opposed to some of the other techniques where you just know that there's no blockage present.
Significant blockage, correct.
Significant
You're
blockage
absolutely
present.
right. Yeah.
Okay. And can I trust, what does it mean to have a normal CTA?
Yes, normal CTA means though you do not have any plaque, okay? And those patients follow up to 5 to 8 years. I mean, the risk of death or cardiovascular death or myocardial infarction is as low as you can get. We're talking about 0.2, 0.3% per year. Then you have those patients who has clear-cut coronary stenosis, more than 80, 90%. Those pretty much you can be sure the patient's problem is related to the stenosis. The main problem the coronary CTA has is when you have a patient with a lot of calcific plaque, sometimes you could have what we call intermediate stenosis, 50, 70%, and you don't know if those lesions are truly hemodynamically significant or not. Remember, coronary CTA is essentially anatomical testing. Not unlike invasive coronary angiogram. When you do a cath and you see a 50, 70% lesion, you know they don't always correlate with the invasive, for instance, fractional flow reserve, which could determine the hemodynamic significance of that lesion. So this intermediate lesion has been a problem because if you have a patient who have 50, 70%, you're not so sure. Oftentimes we end up ordering either functional testing like a stress echo, stress nuclear, or PET, and that could add an extra layer to the management of the patient. Fortunately, there are at least 2 solutions to that problem. We can perform a CT perfusion study, which very much like a stress myocardial perfusion imaging, we can get a resting CTA, so we can look at the coronary anatomy, and we can administer vasodilator, adenosine for instance, do a stress perfusion imaging. Or you do MRI yourself, it's very similar to the stress MRI protocol and image quality. And the study has shown that it correlates very well with the stress MRI, for instance, for assessment of ischemia. The downside is you have to do 2 CAT scans, so that's you get double of radiation and double contrast, although still within relatively acceptable radiation compared to, let's say, 2 days stress SPECT myocardial perfusion imaging. For the last several years, there is a new technology it's called fractional flow reserve by CT, which use computational flow modeling. And with this sophisticated software, you can estimate and calculate the fractional flow reserve associated with certain anatomical lesions that you see in the coronary CT. This study has been reasonably well validated against, for instance, invasive fractional flow reserve. And the performance is very similar to the correlation between invasive fractional flow reserve and, for instance, PET or SPECT. It's not perfect correlation, and some caveat we can discuss later. But the fact is that the main aspect of this CT-FFR make it, I would say, it's appealing because you only need to do a resting image study. So you don't need to do a separate study. This is purely computational. And for the last 5 years, there's a large amount of data showing this technology is clinically accurate, is quite accurate, and there's some advantage of using this technology in decreasing a number of unnecessary cath, and also it's been shown that if you have a intermediate lesion and your CT-FFR is within what we call normal, the prognosis is very good. So now we have a technology who could give us anatomy and also a window into what is the functional significance of the lesion. And that's why, going back to your question in the beginning, it's very appealing. You get both anatomy and physiology with one test. Not perfect, but clinically very useful, and I think our own experience shows that is quite supplemental to our clinical management, and now it's more and more study showing that incorporating CT-FFR to resting CT could be cost effective, to the point that in England it's been recommended by NICE, the National Insurance Health Service, to be is indicated after CTA intermediate lesion was found in patient with chest pain. In our US, the guideline, we are lagging a little bit behind. We're not using that. Our guideline still does not recommend, but I think I sense there will be some changes. Yeah.
Yeah, I've gotten the impression here from our own clinicians who are ordering CTs that there's a big demand for this technology in order to help them manage their patients whenever you have an intermediate stenosis.
Yeah.
Okay, and Su Min, you know, one of the concerns, of course, is nowadays there's a lot of discussions about radiation.
Absolutely.
Our patients are getting more and more radiation, just a lot of it from diagnostic medical imaging. What are we doing in CT to help limit the radiation exposure for us?
It's an excellent question. You know, the radiation, medical imaging is the single most important source of radiation received by population here in the US. And nuclear imaging, CT imaging has a huge, make a huge component of that radiation. And fortunately, as I mentioned in the beginning, there's been so many pretty spectacular, I would say, technological advances that we can obtain a diagnostic CT imaging with very, very low dose of radiation, very acceptable. Just to give you some information, just to put things in perspective. Here in Houston, sea level, we receive annually between around 2.5 to 3 millisievert of radiation just from going out here in the summer with our hot summer. And if you live in Denver, Colorado, it's probably even higher. So now we have technology in the market, the latest generation CT scanner. In a lot of patients, we can obtain a diagnostic coronary CTA with a dosage similar to that background radiation you receive in 1 year. In some cases, for instance, with you, we could probably get a very diagnostic CTA with a proper heart rate control. The amount of radiation you receive, let's say, 2 to 3 months living here in Houston from the background radiation. So we're talking about order of 1 to 2 millisievert. Again, obviously we try to not give patients too much radiation, but 1 to 2 millisievert in the context of getting 3 millisievert just for living here in Houston from every year, I think the information we obtain could help the patient. I think that amount of radiation is quite reasonable, and I think the cost-benefit ratio is clearly in favor of doing the testing. Yeah.
That's very nice. So with low radiation now you can obtain both physiology and anatomy.
Correct.
In one test.
Correct. And that's the reason why I think the European Society of Cardiology had in their latest guideline, essentially coronary CTA and functional testing is considered equivalent. So you can, in patients with up to intermediate pretest likelihood or risk of coronary disease, depending, the recommendation is depending on the local expertise, meaning that like anything else we do in medicine, you need to know what you're doing in order to obtain the benefit that's been published in the journal. So depending on the local expertise, they recommend you can either do functional stress tests that we've been doing, or you start with the coronary CTA.
Start with the coronary CTA. Now I know with CT, there have been some recent trials that have looked at CT compared to functional testing, the standard functional testing that's available to a clinician. What has some of this data taught us?
I think taught us at least is as safe, and I mentioned earlier, it could be even prevent some event. And the key is, remember, the test doesn't affect directly the patient's outcome. It's what we do with the information. So that's one message I want to get through. Doing a stress test or calling CTA doesn't going to change patient's risk. It's the information as a clinician, what we gather from the test, and you have to treat the patient according to their risk and what you find in the imaging study. A patient has to be compliant and have a buy-in to their conditions and your recommendation in order for you or for everybody as a community to make changes in patient's outcome. And I think the main advantage of CT is that I think it offers it's probably a better tool in changing patients' behavior.
And Su Min, this sounds like really a superb technology. At Methodist, what kind of scanners do you have, and how are you employing them?
Yeah, I think the latest generation scanner, you can do either dual source CTA, or wide detector CT. Essentially, unlike any other cardiac imaging, you can obtain a coronary CTA in one single heartbeat or in less than a second. So it's very patient-friendly. Okay, takes longer to put the electrodes on the patient than actually obtaining the images. So we fortunately here in Methodist we have 2 or 3 latest generation scanner, and we work with them day in day out. You can attest that it's quite dramatic. There's no patient that we cannot get reasonably good study for diagnostic purposes.
Thank you, Su Min. We're just going to break away for a 2-minute break, commercial break, and we will join you back here again for further discussions on advances of cardiac CT.
There are a lot of conferences and everyone gives lectures and data, but this is one of a kind where you go in hands-on, using the new technology, experimenting it, getting a feel for the technology, and learning hands-on exactly how these procedures are done and why this technology is so important.
The ISCVS symposium that we are holding here at Methodist Hospital in Houston, Texas, is the largest hands-on symposium in a variety of interventions in the world. It has not been done or achieved anywhere else. This is something that's so unique because we have here state-of-the-art technology, the newest innovations in endovascular field to train and teach physicians how to use and implement this to provide better patient care.
Having such a great wealth of resources and having different X-ray techs at every station, having all of the equipment available to do the jobs that we wanted to do, it was really a great opportunity. It was like having a big endovascular playground where you could test out all of the different equipment in a controlled environment. As a physician assistant, being able to work with the different surgeons and really grow my depth of experience has been a great opportunity.
Well, there's certain things that you can't learn in the classroom, and obviously when you're working as a clinician, the mistakes are costly. So here, You can experiment with the devices. You can try things you've never tried. You have experts kind of guiding you and giving you advice as to how to deal with complications and the procedures, and that's always what I'm looking for. I'm always looking to increase my speed of learning and content, and I think that this hands-on approach is very effective for that.
So welcome back to our new monthly webcast, DeBakey CV Live, Multimodality Cardiovascular Imaging. Again, my name is Faisal Nabi, and I have the pleasure to host Dr. Su Min Chang, who is our, we've been discussing for the last 15 minutes, advances in cardiac CT. And Su Min really shared with us how powerful this technique is, has a very high diagnostic accuracy, has very good outcome data. More and more studies are supporting its use, and a lot of guidelines, at least internationally, are changing to support the use of CT. Su Min, it seems like coronary disease has been really a strength for cardiac CT. What are some new advances where you see CT also, making it, claiming some stake?
Yeah, absolutely. Cardiac CT, we would say that, not coronary CT. There's a difference. When you say coronary CT, mostly we try to focus our attention to coronary artery disease, and that's one of the first reason, or the main reason that cardiac CT was developed to study the coronary disease. But like any imaging study, we can see not only the coronary artery, we can see the entirety of the cardiac structure and the great vessel. It will require a couple more hours just to talk about all the new application. But the most important application the CT has acquired over the last 5 to 10 years is in the arena of structural heart disease intervention. I think almost there's no area of structural heart intervention in which CT does not play a major essential role. Okay, for instance, TAVR, TMVR, appendage occlusion, coronary CTO, complex coronary intervention. CT has become the test of choice to evaluate, to plan, and to even guide the intervention. And we're going to see a lot more data and result. And I think CT has proven to improve the procedural outcome, and is right now, this is not in the future, it's already essential component of any structural heart intervention. Almost unheard of a complex coronary or structural heart intervention without CT. Yeah.
It seems almost any patient who goes now for a TAVR, first line test is to get a CT after the echo.
Absolutely, absolutely. That'll be fair to say.
And I imagine it's because of its incredible ability to see anatomy.
Correct, correct. The spatial resolution of cardiac CT is the best we have in any kind of non-invasive imaging technique.
I know you've done a lot of work even in the realm of heart failure patients who have LVADs.
Yeah, it's a very small group of patients, but we believe that since patients have assist device, oftentimes the echo imaging is have a lot of problem because of the acoustic shadowing, and MRIs cannot be performed in this patient with LVADs, and CT in selective cases because we have to be cognizant of the renal functions and also age of the patient. If it's a young patient, we have to be careful not to give them too much radiation because some of these patients end up in transplant. But for patients who have complication and a ventricular assist device, CT can provide oftentimes answer and can modify how you manage the patient.
All right. Well, it was a real pleasure learning from you, Su Min.
Thank you. Thank you for letting me talk to you guys about cardiac CT. And I guess you can all find our contact information. If you have any question to ask us, we're happy to answer after this program.
This program.